Thank you, Sophia, for passing on the word to me and Mette, and thank you, Mette, for taking your time to spend these 20 minutes with us here in the studio. And what we will discuss here at this webinar is nephroprotective effects in a very particular model of advanced DKD. And one burning question I've had all the day, Mette, is that why did you select this model particularly for this webinar?
Yeah, that's a great question. Right now, I can't really change the slides with this. It doesn't really work, so maybe I can ask Sophia to
hang on for a minute. I'll just get some technical assistance.
Nothing is helping.
There
we go. Okay, that was good. Yeah. Well, beginner's problem. So yeah, so why did we actually, use this model and set up this model? Well, so we work in preclinical drug development, and we know that there's, in terms of rodent models of diabetic kidney disease, there is an association between disease progression and translatability. And if you look at some of the models that are really widely used, they reflect early diabetic nephropathy, such as mild albuminuria and mesangial expansion. These are models such as the ZDF rat or the DBDB mouse. But they translate relatively poorly when we want to test and develop drugs. So in order to establish a model with more advanced phenotype, severe albuminuria and glomerular sclerosis, we can apply certain stressors to these models, such as knockouts or modulators to the DBDB mouse, such as the nephrectomy or hypertension. And that was actually what we set out to do, setting up this model.
Okay, thank you. So what you actually did was to combine the profile of the well-known DBDB mouse on top of urenephrectomy and AAV administration of a renin construct.
Yeah.
How did you actually accomplish it? Can you tell me a bit about the model establishment?
So absolutely. So we obviously had some ideas from the literature. So in 2017, this paper came out in Jason from Harland et al. Describing the use of the renin AAV in various diabetic models to establish a model, a hypertensive model of diabetic kidney disease. And we actually from that established that model in-house. And what we did was actually, using DBDB mice that were urenephrectomized. In these mice, we administered the renin AAV construct, and this is kind of the graph of the blood pressure in these mice. So the control group, they received the bolus of LXC vector, which is a control vector, not inducing hypertension. And then we used different doses of the renin AAV to induce hypertension. And what you can see is that we actually managed to dose-dependently raise the blood pressure in these animals. Alongside this, because it's very nice that we have high blood pressure in a diabetic mouse, but alongside this, we also wanted to look at the kidney damage in these animals, and we used primarily urine albuminuria to investigate this. And here you also see that at least in the lower doses of renin administration, we see a dose response in terms of albuminuria as well.
So you have, using ACR as an overall marker of kidney function, a decline in kidney function, and you have hypertension in the model. How did you actually administer the AAV vector?
Yeah, so the AAVs are administered IV. So we do it as a single injection. Mm-hmm. So in that term, it's really nice and easy to use. So the AAV is primarily homing to the liver, and it's got a liver-specific promoter in front of the renin gene, and so the renin is expressed at high levels. It actually is expressed at such high levels that the endogenous kidney renin expression is basically shut down in these animals. Mm-hmm. Yeah. And we also know that this expression of the renin and the high blood pressure is actually continuing for weeks and even months in these animals.
So now, knowing that you tested different doses of the AAV renin construct,
yeah.
From what you know now, which dose would you go for?
Yeah, so obviously we had to choose a dose. It's really nice with high blood pressure in this model. This is what we aimed for. But we also wanted to aim for a blood pressure that was physiologically relevant. We also see in some of the groups that had these higher doses of renin AAV that we saw high mortality. So we balanced all of these things out and actually decided to go with this 2 times 10 to the 10th GC per mouse.
Thank you, Mette. So in terms of blood pressure, which is an important parameter to assess when working with the AAV renin mouse, how did you do that?
Yeah, so in these studies, we actually used a quite simple method, but also a method that's easy to apply in many animals. So we use this tail cuff method, where the blood pressure is measured in the conscious mouse. So it's fitted in a small strainer, and then we measure blood pressure, basically like you do when you're at the doctor's with a cuff around your arm.
So when looking at your ACR changes, what would you infer from that? Is this a severe effect on kidney function, and can you confirm that on the level of histology?
Yeah, so these are really high levels of albuminuria. I've seen nothing like it in other diabetic kidney disease models, and also we obviously wanted to look at kidney pathology. We have that option in these animals. So here's a small image from a paper we just published, where you can see that you can see the glomerulosclerosis basically in healthy mice, in DBDB uninephrectomized mice with normal blood pressure, and in the hypertensive uninephrectomized DBDB mice in the black bar. And as you can see here, we can quantify glomerulosclerosis, and it's really elevated or enhanced in this model. And what you can also see here, these are representative images from each of the groups, and this image from the renin UNXT-BDB mouse, it's really stunning glomerulosclerosis that we see in this model. And it actually correlates also very nicely with some gene expression analyses that we've recently done. So these are gene expression levels in, again, the same 3 groups, the healthy DBM controls, the uninephrectomized DBDB mice, and the renin UNXT-BDB mice. And these data are actually from the glomeruli only. So we did laser capture microdissection to isolate the glomeruli, and next we did RNA sequencing on them. And what you can see here is in the top panel that markers of podocyte markers are downregulated in the model, which is a key feature also in human DKD. And what we also see is that these genes of extracellular matrix are highly upregulated in the model. So I think these data correlates nicely with the histopathology that we see.
So you would assume that there will occur podocyte injury, yeah, alongside with fibrogenesis,
yes,
in the model.
Absolutely.
So if you could recapitulate, what would you say to me that would be the hallmarks of this particular model compared to other models?
Yeah, so the hallmarks here are the albuminuria, which is really extensive, and also the glomerulosclerosis. Yeah.
Thank you, Mette. So now having established the model, characterized it, also respect with clinical features, what would be the next step to validate this model?
Yeah, and so we did take that next step, and the next step is obviously to validate it using chronic treatment with standard of care, and that's what we've done in a study where we in the renin UNXT-BDB mice did a period of 12 weeks of chronic dosing with 2 standard of cares, one being an ACE inhibitor, lisinopril here, and the other one is an SGLT2 inhibitor, empagliflozin. We did treatment with these compounds for 12 weeks, either as monotreatments or as combination treatments. And as you can see here on the graph on the left-hand side, looking at the 2 bottom graphs, which are the groups dosed with empagliflozin and the combination treatment, you see that we saw a really nice blood glucose lowering effect of empagliflozin in both of these groups. And also looking at albuminuria, if you look at the again especially the the green bar compared to the black bar. The black bar is the vehicle-treated hypertensive diabetic mice. The green bars show a really nice effect of the combination treatment in terms of albuminuria. And the same thing looking at this histopathological parameter, so glomerulosclerosis. Again, we see a really nice and expected effect of the combination treatment with these two standard of cares in the model.
So does that mimic the effect in the clinic of standard of care to control hypertension and hyperglycemia?
Yeah, so we know that so the data that came out in the two big clinical trials, so Creton's trial and the DAPA CKD, they show that most of these patients were treated with a blood pressure lowering drug. Is that they had the SGLT2 inhibitor had additional effects to that. Yeah, so these are the effects that we would expect. So obviously, when we look at these clinical trials, we also look at GFR as a measure of kidney function. We don't do this in our model, but instead we have the opportunity to go in and look at these histopathological parameters, which we know are associated with GFR.
So these parameters will always be important when characterizing drugs in this particular model?
Yes, I think they do.
So now knowing that it's clinical applicable to use lisinopril or any other ACE inhibitor and SGLT2 inhibitor in combination in clinical treatment, and we know that other compounds are in clinical development for DKD, what would you then do to enhance validation of this model and show broader applicability across various drug classes?
That's a great question, and a question we get quite often at the moment. So this is obviously very nice that we're able to show effects with these classical standard of cares. But obviously a lot of things are going on in the DKD space, and we see now new drugs coming out all the time, and really great results from clinical trials. One example is the non-steroidal mineralocorticoid receptor antagonist, so finerenone, and the other drug class, which I think is particularly interesting, is the GLP-1 receptor agonists. Many of the patients that we work with, and also this mouse model, reflect a state of obesity, insulin resistance, hypertension, and so the GLP-1 receptor agonists are interesting because they also induce a body weight loss and also affect blood glucose in the positive direction.
So you will be able to show data on this?
Yeah, so this is actually the next step we have taken with this model, is that we basically wanted to test semaglutide in this case. In the model, both semaglutide alone, but also semaglutide in the combination with lisinopril. And here are some of the you can say metabolic data from the model, where we in the left-hand side are looking at body weight, and we see a really nice body weight lowering effect with semaglutide both alone and in combination with lisinopril. Secondly, we also see the expected effects on blood glucose of semaglutide, which is preserved over the entire course of the 11 weeks of dosing that we did in the study. And finally, we can also see this on the long-term blood glucose, so the HbA1c.
So these effects are classical effects of GLP-1 receptor agonists?
Yes, when looking at the metabolic.
Yeah, and also in this. And also in just in DB mice alone.
Yeah, on DIO mice, if you're working with that type of model.
So that would suggest sufficient exposure.
Absolutely. Yes.
Yeah. Okay.
Yeah.
So then, now knowing that the mice are hypertensive, do you have data to demonstrate that semaglutide has effect on the hypertensive aspect of the model?
Because that was kind of the next step. We wanted obviously to look at nephroprotective effects, but also see if semaglutide alone or in combination with lisinopril did affect blood pressure. And I think these data are actually quite stunning to me. So from left to right, we are looking at diastolic, systolic, and the mean arterial blood pressure in the mice. These blood pressures were measured both 1 week after we initiated the dosing, so that's a, let's say, subchronic effect. And it seems like obviously we have a really nice blood pressure lowering effect of semaglutide, and also in combination with lisinopril. And what I also think is really interesting is that this effect actually lasted throughout the study. So it's not just a a kind of acute effect, but the effects really maintained throughout the entire study period, which I think is rather impressive.
Yeah, it is. And when looking back on your previous studies where you administered lisinopril alone, now knowing these data, if you compare the magnitude effect of semaglutide in this particular study to lisinopril, are they equally effective or?
Yes, and then I think what you really see here with the blue bar, that's the combination effect of semaglutide and lisinopril. And I actually think that based on our previous data, that semaglutide alone is as efficacious as lisinopril alone in this model, lowering blood pressure. So it's really a really nice additive effect that we see here.
Okay, all right. So seeing these very, very nice data and very robust data, I assume that this could translate into histological benefits. And functional benefits.
And I think I will show you some data about that on the biochemistry that we actually look at. Because, so as you mentioned before, I think the hallmarks of this model is really albuminuria and histology. So of course we did look at albuminuria in this model, and what we really saw impressive effects even with semaglutide alone on albuminuria here shown on the left graph. We also looked at urine excretion of this kidney injury molecule 1, which is a marker of proximal tubular injury in the kidneys, and we also see that that's also significantly reduced, in particular with the treatment with with semaglutide. Yeah, so super interesting data.
So that makes me think using KIM1 as a functional marker. Can you also use that histologically wise?
Yeah, so we also do have a histological way to assist that. We do have an IHC stain set up and are able to quantify the KIM1 expression in the kidney, and the pattern looks basically the same as we see here in the urine parameters.
So the changes in circulating KIM1 levels reflect actual improvements.
So we haven't measured circulatory, but we have measured in the kidney, so in the kidney tissue.
All right.
But,
so how about histological data?
Yeah, I know you're dying to see.
Yeah, I am.
Yeah. So again, in this model, we used our setup to look at the glomerulosclerosis, and glomerulosclerosis is normally a kind of a marker that you would score. So you would have a pathologist going through a section of the kidney and score each and every glomerulus that the pathologist would be encountering in the section. What we've done is actually to set up an app using AI and machine learning so that we can do this automatically. And so from a kidney section that is PAS stained, we can actually score basically more than 100 glums per animal in a study like this. And the data, so we score these glums from GS1 0, which is a healthy glum in the bar here, represented as the gray area, and then going towards the darker blue colors, we have more and more severe glomerulosclerosis. And what you can see here, the vehicle-treated hypertensive diabetic mice, they have approximately 60% of the glomeruli that are severely affected, so GS3 or 4. And then when we treat the animal with semaglutide, we are able to reduce the fraction of these severely affected glums. We have almost 60% normal glums in those animals. And now if we have the combination treatment, lowering blood glucose and lowering blood pressure, we're really able to almost rescue this phenotype. And the graph on the right-hand side here really just displays the same data in a bit more digestible way for most of us. So we see a really I think stunning effect of the combination treatment with these two drugs in combination.
So it's quite clear that the model can be treated to reverse
it seems like
the aspects of severe advanced glomerulosclerosis.
Yeah, I think when you hit those two key physiological drivers of the disease in the model, so the blood glucose and the blood pressure, we are able to reverse or protect the disease progression or protect against disease progression.
And that makes me think, can you correlate the ACR changes to the scores? How well do they correlate?
We actually see that they correlate very, very nicely.
Yeah.
So yeah.
Thank you very much.
That's absolutely the case.
And I also assume that these are semi-qualitative data, but you can follow up doing qualitative histology to learn more about the benefits.
Yeah,
of
that's absolutely the case, that you can pick and choose between the marker you like the best. We think that this way of scoring the glomeruli are the best way and as close we can get to the human clinic as possible. Obviously, we don't, as a standard, do biopsies on DKD patients like they do, for example, in NASH. But from the standardized scores that is actually used in diabetic nephropathy, we have kind of leaned towards that as much as possible using this score.
And that leads me to one of my final questions, Mette, because I know time is running. Can we infer from these data that there might be some anti-inflammatory activity of these compounds in the kidney?
Yeah, so I don't know if we can infer that from these particular data that I've shown you here, but there are more data in, I can say from this study that I haven't shown you here today, that would indicate that some of the effects of semaglutide, and that's also what is being discussed in the society at the moment, is that there are anti-inflammatory effects of semaglutide, and it's obviously super interesting to dig further into these effects to understand them.
Okay, thank you, Mette. So learning from your presentation of your data, you tested actually 3 different compounds.
Yeah, no, yeah.
And some of them in combination.
Yeah.
But if you were to choose among these compounds as a benchmarking study against a potential compound with potential DKD efficacy in the model, what benchmarking compound would you select?
Yeah, so I think I would always choose to do a compound in combination, alone or in combination with lisinopril, as we've done here. I think these patients should all hopefully be on a blood pressure lowering drug. So I would always have lisinopril in that combination. But whether I should use an SGLT2 inhibitor or a GLP-1 receptor agonist or something different, I think that's a matter of your specific drug and what you're specifically investigating.
So you actually continue developing the model with regards to pharmacology?
Absolutely.
All right. Thank you very much, Mette. To learn how well this model was validated to pharmacology, but also with respect to the disease phenotype. And I think now it's time to maybe wrap up the relevance of this model in drug discovery.
Yeah.
Can you do that, Mette?
Well, yeah. So I can just say that we think we've established a model that displays features of advanced diabetic kidney disease, and we really strongly believe that this is a contributing factor to improving the translatability and the predictability of the model. I also think that now our second pharmacology study here shows that we're not only able to use these the new standard of care, so the blood pressure lowering and the SGLT2 inhibitors, but also now this drug class where we are targeting more the metabolic aspects of the disease. And I think that's been together really, I think, confirms the applicability of the model. So
what I see from your data is that drugs either working directly on the kidney or extrarenal, they could actually have efficacy in this model.
Yeah, absolutely. I think there are lots of opportunities there.
Thank you very much, Mette. So, am I right, Sophia, that we are approaching the Q&A session?
Oh, yes, we are. And questions are actually starting to tick in. And I'm thinking that we can start out with the clarifying question.